there are different types of studies in epidemiology. This video is about observational studies. There are two different types of studies, observational studies and experimental studies. In observational studies, there is no intervention. All you're doing is you have a bunch of people which are your subject and you're just observing them. In experimental studies, there is actual intervention where you give medications or you certain procedures or whatever, and you see what are the effects of that intervention and the benefits or whatever. So there are different types of observational studies. Now in this I'm specifically talking about observational studies. There's case reports, case series, cross-sectional studies, case control, and cohort studies. The first two are a bit different, case report and case series. They're very simple actually. And a case report is something I'm sure everybody has heard of. You have a single case, you report it, and n equals to 1, which means that the amount of people that you're talking about in your case report is just 1. That's your subject. The disadvantage is that this is just a single case report and there is absolutely no control group. The other type of study is a case series where you have multiple similar cases, so it's exactly like a case report except you just have more than one patient this time presenting with those similar symptoms or similar diagnoses, and you're just reporting their cases. Again, there is no control group. This is just everybody in your study, the n, which is more than 1. Everybody has the disease or has those symptoms or problems. The remaining 3 types of observational studies can be best studied through the understanding of a timeline, where in this case we have this red line which represents the time. Now, this is the now or the present, and this is what's going to happen in the future, and this is what has happened already in the past. So all I'm trying to say is that we can divide the other observational studies based on the time period that we're studying. So if we're studying the current time period or a certain point in time, then it would be right here. Whereas if we were studying something in the future, it would be here, and something in the past would be here. So let's see how this would apply. So first type of study is a cross-sectional study. Now, what is the definition of a cross-section? Well, you know how in histopathology, let's say you take a cross-section of a tissue sample or even in imaging, all you're doing is you have the whole tissue or a sample and you take a specific area or part of it. That's why it's called a cross-section. When the same type of understanding can be applied here, where when we have a timeline, we're taking a cross-section of that timeline. So in that particular time period, like right over here, like currently in the present, we're going to study the cases here. So it's basically you take a cross-section of the timeline and you see how many people have a certain disease. In other words, you're measuring the prevalence of a disease. So let's say you want to know if the risk of lung cancer increases with age. You could take a bunch of people of different age groups and follow them over time. That would not be a cross-sectional study because you're following them over time. In a cross-sectional study, it's just like a tissue cross-section where you just look at that time period and you study that your sample. So in order to make a cross-sectional study, instead what you would do is you would collect data from people of different age groups at a particular time, and you see all the people who have lung cancer in those age groups. So let's say you notice that there are more people in the age group of 60 to 70 years old with lung cancer than in the age group of 20 to 30 years old. Thus you conclude that lung cancer rates are higher in older individuals, but you cannot say why lung cancer is higher in older people. You can just say that it just is. So in other words, in this type of study, you're pretty much just seeing the prevalence of lung cancer, let's say in this case in these certain age groups. Okay, and you can try to link old age to lung cancer, but you cannot say that it's the old age that resulted in the lung cancer, it caused it. All you can say or comment on is the prevalence of lung cancer in that age group or whatever you're studying. The next study is a case control study. In this study, we're looking at the past in the timeline, and as the name implies, case control, that means we have a control group in this study. So this is a retrospective study, And what we're doing is we take a bunch of people with the disease and we compare them with a bunch of people without the disease to see if there is a link between a certain risk factor and disease. So you have a bunch of people that you selected that have already been diagnosed with a certain disease, and you have a bunch of people without that disease. And you want to see if the people with the disease have a certain risk factor or something that they share, or that is common amongst them, as compared to the people who are in the control group without the disease. There is no measure of incidence in this study, and that's because this is a retrospective study. You're not going to see any new cases developing. If you want to see incidence or measure incidence, you want the study to be occurring in the future, so you can see new cases as they develop. And you will not be measuring prevalence either, because the people that you're selecting for this study are people who have already been diagnosed with the disease. So you're already selecting people specifically who have already been diagnosed with the disease. You're not seeing how prevalent that disease actually is in the entire population. The case control study can tell you if a certain risk factor or a certain thing caused or the disease. So there is a causal relationship that can be established. Let's say you want to see if there's a link between cigarette smoking and breast cancer. So you take 100 people already, or patients already diagnosed with breast cancer, and another 100 people without breast cancer. So that's your control group without the breast cancer. You assess in both of the groups how many of them were cigarette smokers, comparing the frequency of cigarette smoking in the case group to the control group. This is an example of a case control study. There is nothing in this study over here that can indicate or tell you the prevalence of breast cancer, because you have selected specifically 100 patients already diagnosed with breast cancer. And neither can you monitor incidence, because you're not, again, you're not following these patients to see if there are any new cases of breast cancer that develop, let's say, in the control group, because this is all stuff that has taken place in the past. The advantage of this study is that you can study rare diseases, as because all you have to do is, control find and find the patients with breast cancer in this case. So you don't need a large sample size either, and that means that it would also be less time consuming. The disadvantage of the study is that it's retrospective, so it relies on memory. That means that there is the possibility of recall bias. For example, in this study, the patients might not be able to recall properly how much they smoke or how much they've been smoking, and that can affect the effectiveness of the study. Again, this can tell you or establish a causal relationship. Like in this case, we can link cigarette smoking to the presence of breast cancer. The last observational study is a cohort study, and it is the best of all the observational studies. This study is looking at the future in the timeline. There is the presence of a control group in this study, and since it's looking at the future, it's a prospective study. And what you're doing is you take a bunch of people exposed to a certain risk factor and a bunch of people not exposed to that risk factor, which would be your control, and you follow both of the groups over time and see how many people in each of the groups develop a certain disease. So therefore, this study is the only observational study that can identify incidence, because you have a bunch of people over here that you took. Everybody does not have the disease, and you follow them over time and to see how many of them and which ones of them develop the disease. So you start getting an incidence rate over here, because you can see the disease as it develops. And it's the best study to establish a causal relationship, which would be relating that risk factor to the development of the disease. And that's because you're actually following the people in real time, so you physically can see the disease as it develops, and therefore more accurately relate that risk factor to the development of the disease. Here's an example of a cohort study. Let's say you want to know if smoking marijuana is linked to lung cancer. So you take 1,000 marijuana smokers and 1,000 people who do not smoke marijuana, which would be your control group, and you follow them over time to see how many in each of the groups develop lung cancer. Therefore, you're checking the incidence. One thing you can notice is that you need a large sample size, and that's because it's not necessary for all those people, or for a lot of those people, to develop the disease. So the larger the sample size, the more easier it is for you to have an effective cohort study. Whereas in a case control study, you don't require that large of a sample size, because you're already selecting people who have already developed the disease. So that's another disadvantage. Again, it can also be time consuming and expensive. That's because um, you have to spend a lot of time with the patients and monitor when they start developing the disease. So for example, in this case, lung cancer, you know, it's not something that's going to happen in 1 or 2 months. It takes time. So you would have to spend a lot of time, and this cohort study would take a long time for it to be effective. The advantages were already discussed in the previous slides. Now let's look at analyzing observational studies. So these are the three main studies I talked about from the observational studies. There's cross-sectional, case control, and cohort studies. Each one of them has its own separate way of analyzing the data. Cross-sectional studies uses chi-square, which is something that would be covered in biostatistics. Case control uses odds ratio, and cohort uses relative or attributable risk. First, let's talk about odds ratio. Odds ratio is something that can be used for case control studies and also can be used for cohort studies. However, it's more commonly used for case control studies. So there is a difference between probability and odds. The probability is the likelihood for an event to occur over all the possibilities. For example, if you have a league of 20 teams all competing for one championship, the probability for one particular team to win that championship would be 1 over 20, because that's one team over all the possibilities, which includes that team plus all the other teams winning, the possibility for all the other teams winning, so that would be 1 over 20. Whereas the odds is how likely it is for that particular event to occur over how likely it is for that particular event to not occur. So in this case, the odds of that particular team to winning would be 1 over 19, because the 1 represents the likelihood for that team winning, and the 19 represents the likelihood for that team not winning. So probability again would be 1 over 20, and the odds, however, would be 1 over 19. Now an odds ratio is a ratio of two odds. Odds ratio is when you compare how likely it is that a particular event or disease will occur in someone exposed to a certain thing versus how likely it is that a particular event will occur in someone not exposed to that specific thing. So in other words, what you're trying to do is you're trying to link risk factors to a disease or to that particular event. So you're identifying risk factors and you want to see which risk factor is most commonly or most strongly attributed to that disease. Odds ratios can be applied differently. For example, here there's one study from 100 people diagnosed with breast cancer and 100 people without breast cancer. You see how many were smokers in each group. Then you can calculate what are the odds that someone with breast cancer was a smoker versus the odds that someone without breast cancer was a smoker. This is a retrospective study, so it's a case control study. And in this case, you would use odds ratio. And here we have another study. If I smoke, what are the odds that I will get lung cancer than if I don't smoke? Well, if you can make a cohort study for this case, and this would be a prospective cohort study, and you can still determine or use odds ratio in this case as well. The use for odds ratio is for comparison. So what you could do is you could identify different risk factors associated with a certain disease in your study, and you could calculate the odds for or odds ratio for each one of those risk factors, and you can compare those odds ratios, and we can determine then which risk factor is most strongly associated or linked to that disease versus which one is the weakest association with that disease. So if you have an odds ratio that is equal to 1, that means that the exposure does not affect the outcome. And if you have an odds ratio that is less than 1, it means that the exposure negatively affects the outcome. In other words, it decreases the odds of an outcome or a particular outcome, such as a disease occurring. So if you have a risk factor that gives you an odds ratio of less than 1, it means that that risk factor has a negative effect on that outcome. So in other words, you can kind of say that that risk factor is actually protective against that disease. Whereas if you have odds ratio of more than 1, that means that exposure positively affects the outcome. In other words, increases odds of outcome occurring. So in this case, if you have an odds ratio that is more than 1, you could say that a particular risk factor increases the likelihood or is more strongly associated with that outcome or that disease occurring. Now we come to calculating odds ratio. This is an example of a study that I made up completely by myself. A study was conducted amongst 100 participants to determine the association between cigarette smoking and rhabdomyosarcoma of the heart. 40 of the 50 patients with rhabdomyosarcoma of the heart were known cigarette smokers. Of the 50 people in the control group, 5 were known cigarette smokers, determining the association between cigarette smoking and rhabdomyosarcoma of the heart, according to this study. So first of all, we want to know what kind of study it is. There are some clues, such as the sample size being just 100 people. That is something you would not find in a cohort study. Another thing is rhabdomyosarcoma of the heart, which is an extremely rare disease. So that's also something you would more likely find in a case control study. Another thing, and the most important thing, is that in this study we're looking at people who already have rhabdomyosarcoma of the heart. So they're already diagnosed with a certain disease. So in our selection, we took 50 people who already have that disease. So this is a case control. This is not a cohort study. Okay, now since we want to know what is the association between cigarette smoking and rhabdomyosarcoma of the heart, we want to determine the odds ratio. So now we're going to see what are the things or the important things that we need to recognize from this question. So we want to first of all know what they're asking for, the risk factor. What is the risk factor or the exposure? And in this case it would be cigarette smoking. And what is the outcome? In this case it would be rhabdomyosarcoma of the heart. Now so here we have a disease or the outcome, which is rhabdomyosarcoma of the heart. Risk factor or the exposure is cigarette smoking. So we have 50 people in the disease cases and 50 from the control. And of these 50 in the disease cases, these are 40 are smokers, 10 non-smokers controlled, 5 are smokers, and 45 are non-smokers. So odds, remember, is the likelihood for an event to occur divided by the likelihood for that event not to occur. So if we wanted to see the likelihood for somebody to be a smoker amongst the rhabdomyosarcoma cases, we'd see the likelihood for them to be a smoker amongst those cases divided by the likelihood for them not to be a smoker amongst those rhabdomyosarcoma cases. So of the 50 people who have rhabdomyosarcoma, 40 of them have, since 40 of them have or are smokers, so that would be over here, and 10 are non-smokers. And so that's the odds for that. And then the odds in the normal or the control group would be likelihood for somebody to be a smoker amongst the normal or control divided by the likelihood for somebody not to be a smoker amongst the control group, in this case, which would be 5, because 5 are smokers and 45 are non-smokers. So 5 over 45. Now what we're going to do is we're going to calculate those odds. So the odds for this case group would be 4, and the odds here would be 0.11 in the control group. And then we're going to check out their ratio, so it would be 4 divided by 0.11. And if we did that, we get an odds ratio of 36, which is huge. It's something that is crazy number, because this is a made-up scenario. Anyway, so since the odds ratio is more than 1, that means the exposure, or the risk factor in this case, has a positive relationship to the disease or the outcome, which would be the rhabdomyosarcoma of the heart. In other words, we can safely say that smoking does have an effect on presence of rhabdomyosarcoma of the heart. The odds of being a smoker are 36 times greater. So one way that we could say this or conclude this is that if you are a smoker, you are 36 times more likely to develop rhabdomyosarcoma of the heart. But that's incorrect, because we did not take people who are smokers and follow them over time and see how many of them developed rhabdomyosarcoma of the heart. No, we started the other way. We took people with rhabdomyosarcoma of the heart and just looked at how many of them were smokers. So instead, the better conclusion would be that the odds of being a smoker are 36 times greater for someone with rhabdomyosarcoma of the heart than someone without rhabdomyosarcoma of the heart. Now this is just to understand the concept, but on the exam, what you want to do is you want to use an easier method. So you would make a table here, and here what we would do is we would put the risk factor, or the presence of the risk factor, here the absence of that risk factor, and here we have the people who are diseased, and here the people who are in the control group, meaning the ones without disease or the ones who don't have the outcome, in this case rhabdomyosarcoma of the heart. So in this column, all the people who are in our case group, and all the people over here are from our control group. Ignore the letters right now, but so we're just gonna put all the numbers here. So 40 who are smokers, and they had the disease. 5 who were smokers but did not have the disease. 10 not a smoker but still have the disease, and 45 not a smoker and don't have the disease. Now the formula, if once you make this table, there's a simple formula that they use. It's called odds ratio is equal to A divided by C over B divided by D. And if you make it simpler, it becomes odds ratio is equal to AD, meaning A times D, divided by B times C. This might seem complicated, but you just have to remember this formula. Odds ratio is equal to AD over BC. One of the ways that they remember it is AD is in the timeline, or divided by BC, before Christ. So after, I don't know, is this called after Dominion or whatever it's called? And this is before Christ, so AD divided by BC. Okay, so now all you have to know is which cells are A, which cells are B, which is D, and C and D. Well, one way to remember it is that the A cell is always in the top left corner, and the D cell is a diagonal or opposite to it over here, which is over here. The other way to remember is that A are the people who have the risk factor and have the disease, and D are on the completely opposite of this or the other end of the spectrum, where they don't have the risk factor and they don't have the disease. Okay, so and B and C are the others. It doesn't matter if you call this one B or you call this one C, because in the actual equation you're just multiplying them. So in this case, what we would do is we would have 40 multiplied by 45, right? Because the risk factor plus disease, which is the 40 cases, multiplied by risk factor, no risk factor, and no disease, which would be 45. So 40 times 45, 5 divided by the other people, which would be 5 times 10. Right, so 40 times 45 divided by 5 times 10, which is 50. And if you calculate that, the odds ratio that you get in this case would be 36. So that's the other way. And again, it still makes sense, because essentially what you're doing, for example, if you look over here, A divided by C, all you're taking is the people who are from the case group who are smokers, the odds of being smoker divided by, for them not to be a smoker, in this case 40 divided by 10, and divided by here, from the control group, 5 divided by 45, so 5 who are smokers divided by 45 who are not smokers, which is exactly what we did in this whole scenario over here. So in the end, you don't have to remember anything except except first of all, you just have to recognize that this is a case control group or a study where you have to determine the odds ratio, and then you as long as you can divide your cases like this and thus make a table, and you remember the formula, you're good to go. And you don't even have to remember the table, as long as you remember that you're taking the people who have the risk factor and have the disease, amongst the people who have the disease. So risk factor and disease, which is 40, multiplied by the people without the risk factor and without the disease. In this case, 40 times 45, divided by the multiplication of the others, which would be 5 times 10. So 40 times 45 divided by 5 times 10, right? The next type of study is a cohort study. This study uses relative risk and attributable risk to analyze its data. First thing you should remember is that cohort study is the only study that tells you the incidence, and that's because it's the only study that is a prospective study, meaning looking into the future. So the two terms are relative risk and attributable risk. Attributable risk is also known as absolute risk reduction, and both of these risk values, they require incidence data for their calculation. That's why they're limited to cohort studies. Risk is when you ask yourself, what are the chances something will happen or occur? For example, you may ask, what is my risk for developing IBD? Risks can be compared. For example, somebody might have a 1 in 10 chance of developing IBD. In other words, the risk for developing IBD would be 1 in 10, which is 10%, whereas somebody who has a family history of IBD might have a risk of 5 in 10 for developing IBD. So we can compare these two risks. In the first case, 10% risk, and in the second case would be 5 in 10, which is 50% risk for developing IBD. So we can say that the risk is 5 times greater for patients with or people with a strong family history of IBD to develop IBD than in somebody without a family history of IBD. Relative risk and attributable risk is when you compare two risks. In relative risk, we divide two risks, and in attributable risk, we subtract two risks. I personally like the term absolute risk reduction instead of attributable risk because it has the word reduction in it, which tells you that you're subtracting two risks. Relative risk is how much more likely is it for an outcome to occur in someone exposed versus in someone not exposed. Remember, in a cohort study, you have a bunch of people with a certain exposure and a bunch of people who are not exposed to that exposure. And you monitor in both of them to see which ones of them or how many of them in each of the groups develop a certain disease or outcome. For example, if you take a bunch of people who smoke and a bunch of people who don't smoke and you follow them over time to see which ones of them develop lung cancer. First of all, the outcome, which is developing lung cancer in this case, is basically incidence because that is what you're monitoring, which ones actually develop the disease. So let's say that you had 100 people who smoke and 100 people who don't smoke. From the 100 people who don't smoke, 10 of them develop lung cancer in the future, over the next let's say 50 years. And from the 100 people who smoke, let's say 70 of them develop lung cancer in the future. We can compare that risk. In the first group, we had an incidence of 10 people from 100, which is 10 in 100. That is the incidence rate. Whereas in the second group, which is amongst the smokers, we had an incidence rate of lung cancer, or the outcome, being 70 over 100, which is 7 in 10. So in that case, we have two incidence rates. We have 1 in 100 and we have 70 in 100. Now we can compare those two and decide what is the relative risk. In other words, relative to the people who don't smoke or the people who are not exposed in this case, how much is the risk greater for somebody who is exposed to smoking in this case for developing a certain outcome, in this case lung cancer? Is it 2 times as likely, 3 times as likely, maybe even half times as likely? And so in this case, our relative risk would be 7 times as likely. So if we compare the 70 and the 10, we can see that 70 is 7 times the 10. That means that in the group who were smokers, they were 7 times as likely to develop lung cancer when compared to the group who don't smoke. Attributable risk is when you ask yourself on how many more occasions did the outcome occur in someone exposed versus in someone not exposed. So in this, you're looking physically at the amount of cases that you had in the ones who were exposed versus the ones who were unexposed. So in this case, since we had 70 people who developed lung cancer versus the 10 people who developed lung cancer in the non-smokers, we could say that we had 60 more cases, 60 more cases. Therefore, our attributable risk would be 60 cases. In other words, we can attribute those 60 cases of or those 60 cases of incidence of lung cancer to the risk factor, or to the exposure, which would be smoking in this case. This is the equation for relative risk. It's quite straightforward. You take the incidence or the new cases of the outcome, in this case lung cancer, amongst the exposed group, in other words amongst the smokers in our study, and divided by the incidence or new cases of the outcome, which is lung cancer, in the unexposed group, or in the group that does not smoke. So in our study we would say 70 in 100, which was our incidence for lung cancer amongst the smokers, and you divide that by 10 in 100, which is the incidence of lung cancer in the unexposed group. And 70 in 100 is basically 70%, you can call it, or you can call it a 0.7. So let's stick with 0.7, and so it would be 0.7 divided by, here would be 0.1. And if you calculate that, 0.7 divided by 0.1, and we get a relative risk of 7. Now that means the relative risk is more than 1. That means that the exposure caused, or you could say had a positive correlation to the outcome. So again, amongst the smokers, or if you smoke, you're 7 times as likely to develop lung cancer, whereas compared to if you don't smoke. And if the relative risk was 1, that would mean that there would be no difference seen, and that's imagine if we had 10 people who developed lung cancer in the exposed or in the smokers, divided by 10, let's say, who also developed lung cancer in the unexposed. In this case, we would have 0.1 divided by 0.1, which is equal to 1, and clearly there was no association then, or no increased relative risk, you could say. If the relative risk was less than 1, that would mean that there would be a negative correlation. For example, if we were to notice that amongst the people who smoke, their incidence was 10 in 100, and amongst the people who did not smoke, the incidence of lung cancer was 70 in 100, then we would have 0.1 divided by 0.7, which would give us a relative risk of 1 over 7, which is less than 1. That would mean that if, basically what that would mean is that if you smoke, you are 7 times less likely to develop lung cancer. And now for attributable risk, or you can also call it as absolute risk reduction, you take the incidence in the exposed group and you subtract here the incidence in the unexposed group. So in this case, our incidence in the exposed group was 70 in 100, or you could say 70 minus the incidence in the unexposed group, which would be 10 in 100. So let's say 70 minus 10. Therefore, we would get an attributable risk of 60 in 100. That means that, again, as we discussed earlier, those 60 cases can be attributed to the exposure. Well, can attributable risk be negative? Well, yes, it can. Just like the relative risk, it can also be negative. So let's say if the incidence in an exposed group was 10 and incidence in unexposed group was 70, in this case our attributable risk would be negative 60. Therefore, we could say that when in the group that was not exposed, in other words, the non-smokers, we noticed 60 more cases of lung cancer, or you could say it the other way, that in the group that smoked, we noticed 60 less cases of lung cancer. The last thing to talk about is number needed to treat. Number needed to treat tells you how many people do you need to treat or do something to in order to prevent one case of outcome. There is an equation for it, and the equation is 1 divided by attributable risk. So for example, in the previous question, our attributable risk was 60 in 100. So 1 divided by 60 in 100, which is basically 1 divided by 0.6, gives you 1.6. Another way you could look at it is that since the absolute risk reduction or attributable risk is 6 in 100, meaning 60 over 100, the inverse of that would be 100 over 60. So we just flip this and it becomes 100 over 60, and that will also give you the same answer, which is 1.6. And that means that for every 1.6 people treated, or for every 1.6 people that you did something to, one case of that outcome will be prevented. This is a good summary for observational studies. Here we can see this is the timeline, and if we remember that our study can show or represent the current or the present, or it can represent or look at the future, or it can look at the past. So the study that looks at the current is a cross-sectional study, and the one that looks in the future is a prospective study, which is a cohort study, and the one that looks into the past is a case control study or a retrospective study. And we know that when you look at the present or in a cross-sectional study, you are going to be able to measure prevalence. However, in this study there is no control group and there is no causality that is able to be assessed. And we know that as for our data analysis in this type of study, we use chi-square or chi-square, and that's something that would be covered in biostatistics. As for the past or the case control, we know that there's a control group. Same with cohort, there's also a control group, and there's also causality relationship that can be assessed in both. However, the data analysis in this is odds ratio, which is again the formula ADO divided by BC, and whereas for cohort, what you can use to analyze the data is relative risk and absolute risk, as well as number needed to treat, because these are all values or calculations that require incidence. And that also means that in a cohort we have incidence, or we can measure incidence. It's the only one that can tell you incidence. Another difference between case control and cohort, we know that case control, you just need a small sample size because you just have already people who are already diagnosed with a certain disease, and it requires less money and less time therefore. And the cohort study is opposite and requires more money, time, and sample size.